Well, the ovaries are another cause of pelvic pain. Corpus luteum cyst, polycystic ovary disease, torsion, cyst rupture, or infection. All of these can cause ovarian causes of pelvic pain. Here you can see in vivo the corpus luteum cyst, about a 2 centimeter mass. In vitro, the mass with small low-level internal echoes. And finally, on the excised specimen, here's the ovary, and nice sort of 2 centimeter corpus luteum cyst with no blood in it. Corpus luteum cyst, traditionally a stellate appearance, having a ring of fire, a very, very vascular periphery with high velocity flow. Quite typical ovarian cyst or corpus luteum cyst. Here's a 25-year-old who came in for dyspareunia and on examination had this enlarged left ovary, which on examination was the area of focal tenderness and was the cause of her dyspareunia. Quite typical enlarged ovary with peripheral follicles seen on long axis and on transverse scan. So this is polycystic ovary disease. Here's a beautiful example, a water bath specimen, multiple follicles in the periphery. There's the ovary and there's the ovary bisected. Again, a very nice example of polycystic ovarian disease. Ovaries are enlarged in 65% of the cases, 10 to 12 follicles, less than 5 millimeters in diameter. There are other causes for pelvic pain, and here you can see an ovary that is somewhat distorted, and there's an echogenic mass associated with it. And this is often called the tip of the iceberg sign for a dermoid. But the best way of assessing the size of the mass is actually with a bimanual examination where the probe is in the vagina and the hand, examining hand, is on the anterior abdominal wall. And you can see by moving this mass back and forth, you can actually get a sense of exactly how big it is and confirm that this was an ovarian dermoid. Here's a patient who had some pain and fullness. She has a big mass on transabdominal examination. You can see the uterus is displaced posteriorly, no vascularity within it, and you can see on a sweep these linear bands and this big mass with distal shadowing. Well, the linear bands, bright linear bands that you can see here, is hair within the fluid component of this large dermoid. We delivered this dermoid at surgery, and you can see when they opened it up, the wall was relatively thin. There was some hair within the fluid. This big mass that we see over here with dense shadowing, was this a fatty mass or was it bone? And in fact, it was a big fatty mass with hair. And finally, the rest of it was then like a soupy fluid collection of fat. So very typical features of an ovarian dermoid that can also present with pelvic pain or pain and a mass. Ovarian torsion, localized pain with a large edematous ovary, small peripheral follicles, some free fluid, and impaired or absent blood flow. Here is a patient, 29 years old, 1 day of pain, transabdominal scan, normal uterus, enlarged mass with a cystic area. You can see that at laparoscopy, there was no vascularity within that mass. At laparoscopy, you can see the big blackened mass of the necrotic ovary. When they removed it, again, the correlation with this big necrotic ovary with the big irregular cyst seen on ultrasound was perfect. Here we have the uterus here on November 4th on a patient with left lower quadrant pain, nice normal uterus, a cystic mass anterior to it, a solid mass posterior. That solid mass you can see is being measured, and the solid mass has normal vascularity. So it's a big cyst with an ovary that looks normal, but the patient came back 5 days later, and now the cyst and the solid mass are reversed. The solid mass is much larger and avascular. And this patient actually had a cystic mass, which was a hydrosalpinx, which had torted and pulled along the ovary, and now she has an infarcted ovary as well. Ovarian cysts. This patient was known to have bilateral ovarian cysts. The right ovary is now normal. There still is a cyst on the left, but there's free fluid, and this patient has ruptured one of the cysts, which was the cause of her acute pelvic pain. The vagina is another cause of pelvic pain, but very uncommon. I'm just going to pass right through it. But next is bowel. A bowel is a very important cause of pelvic pain, both the appendix or the sigmoid. But you have to look behind the uterus to see it. So, sigmoid, colon, diverticulitis or abscess, a cause of pelvic pain, often missed. Appendix, appendicitis, and torsion of the appendix epiploica. So here you can see a patient, 53 years old, left lower quadrant pain. The uterus is normal. Both ovaries are normal. And do you stop there? Or do you go on and look for what is the cause of the pain? So if you look for the cause of the pain, and you can look in the bowel in the left lower quadrant, you can see thick-walled bowel. This is absolutely abnormal. Thick-walled bowel with some striations, no significant increased vascularity. This is an abnormal loop of bowel. If you compare it on the right-hand side to a loop of bowel, which is normal, this is an abnormal loop of bowel. Let's look now, and there's actually a diverticulum with a distal shadow. So this is diverticulitis with an inflamed area of sigmoid colon. What's interesting is on a real-time scan, you can see normal bowel on the right side, contracting with a lot of fluid within it. And if you look at that abnormal segment as air passes through it, you can see that thick wall that in fact doesn't collapse. And that's an absolutely abnormal loop of bowel. And had you not looked for that, you would have missed the diagnosis. Of course, here's another patient, and you can see masses adjacent to them that have, in fact, abscesses within them, diverticulum and abscesses. Here's a patient who was pregnant and came in with left lower quadrant pain, nice normal fetus, but here you can see a loop of bowel with a diverticulum. Well, you might say on that one shot, it'd be hard to call a diverticulum, but in fact on the cine, you can see there is, as you sweep in and out of it, there is the beautiful diverticulum, and that was the cause of the patient's pain. You can have rather large abscesses with air within them, often seen better on CT scan. Now this patient has abscesses within loops of bowel. May be very difficult to see. All you're going to see really is echogenic fat within the loops of bowel. And in the right lower quadrant, this patient had tenderness. They were wondering about ovarian torsion. There is the ovary, and there is the inflamed appendix sitting on top of it. And as we do a sweep, you can see the inflamed appendix sitting right on top of that otherwise normal ovary. So not very common, but look for appendix and look for left lower quadrant, look for sigmoid diverticulitis. An unusual case, normal tube and ovaries in this patient with pain, except we saw this tender mass. I had no idea what the mass was. I knew it was fatty. When they operated, this patient had a torsion of the appendix epiploica, these fatty masses on sigmoid colon. Well, there are many causes of pelvic pain: the uterus, the tubes, the ovaries, vagina, the bowel. masses within the peritoneal cavity, the retroperitoneum. Remember the bladder, remember cystitis, remember bladder calculi or distal ureteric calculi, and even pelvic muscles can cause pain, not something we often think about. So there are many causes of pelvic pain. The important thing for the examiner and for the physician is answer the question. Thank you very much.